Thank you, Chair, and thank you, Co-Chair. Thanks to my colleagues, who have been presenting over here. Thanks to the audience and to the Ministry of Health staff from Kenya who are over here. And I want to acknowledge them for taking pains to come and sit in this hall, and my other friend from the UN family over there behind. So, guys, I'm going to talk about setting up of a technical support unit, a national technical support unit, which was set up within the Ministry of Health, Government of Kenya, to primarily support the government to scale up its key populations programs, primarily with the female sex workers, the MSMs, the MSWs, the transgenders, the injecting drug users, some migrants, and some long-distance truckers as well. This is a 2-year-old unit, and I'm sure everybody knows in this room what a technical support is, but then we have added another dimension to it, a technical support unit, which is based within the government itself. Just to give you a quick background, in terms of Kenya, we actually have a raging epidemic amongst the sex workers, the MSMs and the IDUs, and this is the current key estimates for the key populations, wherein we have around 130,000 plus female sex workers, around 21 to 22,000 MSMs, and close to around 18,000 plus IDUs as well. We don't really have a good estimate or a good handle on how many long distance truckers are there, but then there are some estimates which say that there could be at least maybe 10 to 15,000 long distance truckers as well who are vulnerable to HIV. We also have a huge fishing population, primarily in the Lake Victoria region, who actually have a prevalence of as high as 30%, but we still don't have really good estimates around that. But given the TSU mandate, we are basically covering the female sex workers, the MSMs, and the injecting drug users. And this is across the country. In terms of prevalence for HIV, we see very high prevalences. It is as high as 30% amongst female sex workers. There are some studies by Baral published in Lancet in 2012, which talks about prevalence as high as 52%. 52%, sorry. The MSM prevalence is close to around 18%, but there are other studies which put the figures to as high as 30%, and the same thing with the IDUs. If you read the global estimates of IDUs, which was published by the World Bank, it tells you about the prevalence of IDUs, the HIV amongst IDUs as high as 30%. And I guess, people who in this room who were in the yesterday's launch of WHO guidelines for the key populations, and there was a presentation done by Tim Hallett who actually made it, said very explicitly that till the time we don't work really with the key populations, we really can't make a dent in the epidemic. So this is a very important group, which we are looking at. And I'm going to talk about why did we talk about a TSU within the government systems. Number one, I'm sure many of you have worked with the government or in some or the other form supporting government. You would discover that working within government, you discover that it's not that governments don't have money, or it's not that donors pooled monies is not enough. The issue is, even though there is adequate funding, there is very little to no monitoring or inadequate monitoring from the partners or from the government itself as to how this money is being spent, which actually ultimately leads to basically poor program quality. And I'm sure you all would have experienced that at some level. We find that programs are really designed based on a lot of whims and fancies, donor requirements, so on and so forth, especially if the government is not funding programs. And that's one level of one level. The other level is also there is little to no program reporting itself. And I'm sure people who have worked in countries like India, would realize how important program reporting data is, and it actually tells you what really is happening in the country. If I ask you a question, from whichever country you have come, I ask you, okay, tell me how many sex workers in the last month went to an STI clinic for STI screening. How many would know this question? Or how many condoms were given to the sex workers last month? Now, and these are important questions, by the way. The other thing which is quite critical is we have a tendency to blame the government. Government is not doing enough. Government is not doing enough. How many people does the government have, to manage a program with close to around 200,000 key populations? I'm giving the Kenya example. There are just two. who are paid by the government to manage a program of a scale which covers 200,000 key populations, and we expect them to do magic. You see, they are not magicians. They're not superhumans. Am I right? And then the other thing is that that's one thing. The other thing is that they might also not have adequate technical competencies to manage key population programs as well. And we need to realize that, it's easy to play blame game. It's difficult to support. And let's get that, let's get that in order. And also at times, we see the people in the ministry, and I'm sure people from the ministry can vouch for it. Close to around 70 to 80% times, they are actually in meetings and workshops and conferences and other things. And that's also important. So, 2 people managing close to around 82 programs in Kenya, spread across the length and the breadth around 1,000 kilometers, both sides, is not an easy thing. And that's where technical support, units come into picture. The other thing is the entire area of duplications and overlaps, wherein you would discover a donor A, funding the same geographies, donor B also funding the same geographies, donor A working with the same sex workers, donor B working with the same sex workers, and I'm sure most of the people who have worked with key populations would have discovered this. The last thing is that we also discovered that in countries, at least where we have worked, and Kenya as well, and at least when we were there, is that, sometimes there are guidelines, but it might not be the best. And there are guidelines, which need to be written. There are some populations who have not been even touched by guidelines or policies and so on and so forth. And there are little to no program monitoring standards. So a program which works with sex workers, if we have I'm sure you might have heard of peer education, if I'm right. So one peer educator working with 20 sex workers is good enough. But there are programs which also work with one peer educator covering 2,000 sex workers. That is also good because they don't really have a standard. And given this context, at times the programs with key populations don't deliver as well, given this lack thing. The other also general understanding is that we as practitioners on HIV prevention, we expect the government to do everything. The magic part of it. We want them to develop guidelines. We want them to issue guidelines, policies, do fund release, administration, develop monitoring tools, so on and so forth. There's a lot of things which we expect from the government to deliver. Not only in key populations. You take the VMMC programs, you take the PPTST programs, so on and so forth. But you see, 2 people, 3 people cannot work wonders. And we need to really recognize that. So in Kenya, given this context, we actually established a technical support unit, which is a team of 15 to 20 people who were hired by the TSU, funded by the donors, and the decision was that these fellows would be working as government staff within the government systems. They would not be outsourced. They would be actually insourced by the government, and they would represent the government as well. And they would be the key technical hands of the government working within the system. So rather than criticize, let's change the way the government works. So if you see the differences over there, the white blocks are still done by the government, and the green is done by the technical support unit, which has been based within the government systems. So when I talk about the government systems over here, I mean Ministry of Health, I mean NASCOP, which is National STD/AIDS Control Program by Government of Kenya. So the government, government's responsibility is to develop guidelines. The role of the TSU is to help them support in developing the guidelines and doing the background work for it. Government's job is to fund release. The TSU's job is to develop monitoring tools, so on and so forth. So the green is government-led, the white is, or the lightish blue color, is basically the role of the insourced units. So it actually works together, and the responsibilities are shared between the government and the technical units which are based within the government. So this is another schematic for it, which talks about the role of government, which is to issue guidelines, administration, reviews, fund flows, handling public inquiries, so on and so forth, which the TSU does not do, incidentally. TSU does technical input, develop tools, develop M&E systems. They are the feet on the ground. So if a program is running, 82 programs running in Kenya, it is the responsibility of the TSU to visit these 82 programs regularly, routinely, and see how they're doing, what's wrong, what's right, and help them improve the programs as well. Then provide the oversight to the implementing partners and do problem solving and strategic planning at the ground level to really help partners achieve results. So for Kenya, the TSU was set up by the Ministry of Health, Government of Kenya in 2012. This is, I would say, mid-2012. We actually hired a team of 11. Now we are close to around 15. And these guys were actually hired, who had really, really high skills on working with key populations, who have been sensitized on working with issues for female sex workers, MSMs, and PWIDs. We also did one more thing in terms of ensuring that the TSU and the government was very responsive to the partner requirements. We placed our staff regionally across Kenya. So we had people being placed in the coast regions. We had people being placed in Nyanza, in Western, in Central, and Eastern, and Nairobi as well, which forms the bulk of the sex work programming. We had no reporting. So if I ask before 2012, how many sex workers were being reached, or how many programs were there even in Kenya, we really had no idea. So our first job was to really put in a system wherein partners started reporting back to the government. And this was critical. And this I will speak in the next slide as well. The other thing which we did was to really mentor and do a lot of hand-holding support to the programs which were working with the key populations. We take it for granted that if we give a grant to the NGO, they will deliver. No, not really. You really got to work with them, quite a bit to help understand even the key population issues to begin with. So till December, that's the time I submitted the abstract. We had actually done close to around 361 days of field visits, covering 29 plus counties, 80 partner locations. If I give you the data as on June, we have done close to around 700 plus days of field visits, covering all counties wherein the programs are there. We have done close to around 75 plus insight trainings as well for the key population implementing partners, and we do this routinely every day, every month, every quarter. And if there is any special request which come from a partner, we ensure that we are there in that particular partner location the next day. So key results, this is just the beginning. Number one, we did map the key populations, across Kenya. In fact, that's one of the first things which we did when we came to Kenya. We actually did a mapping to get your baselines into place, the denominators into place, so that we know what we are being compared against. So we mapped the female sex workers, MSMs, and IDUs. Then NASCOP did a consensus report which brought in data from across the partners to come up with consensus data, which I had shown earlier. We mapped the implementing partners itself, because we really did not know as a government as to who was working where, with whom, and for how much, and with what populations. In fact, that was done, and now we know. And if you ask me, I will be able to tell you as to exactly how many people are being covered, where are they being covered, and what they are doing. We did 5 regional, we actually developed a reporting mechanism for all partners. And if you see, we actually had a zero reporting, and now we have a consistent 95% plus reporting every quarter, unfailingly. We were one of the maybe I would say the 5 countries which actually use program data for program analysis in this world. We do data analysis, for all the reports which come into the government. The government gets the feedback. The government has hands-on data as to who's doing what, where, and whether they're doing a good job or not doing a good job. There are program performance reviews, so on and so forth. And also the donors get to know whether their money is being used and they're delivering the right results. Because what we keep on saying, that if we put in $1, you should get back $1 at the ground level. So if you're putting $100 and you get only 20 sex workers coming into your clinics, that's just 20% results ultimately. So this is a graph for the MSMs, IDUs, and FSWs. There are I haven't put other things on migrants and truckers, which is also available. So this is good. I would suggest if you are working with the government, please help the governments to get reports from all partners across the board. And this is the biggest contribution you as a partner can ever make in a government program. The other thing was, given a lot of hand-holding to the programs, we also found general improvements in service uptake. We saw that because of the field presence, because NASCAP was now working directly with partners almost on a daily basis, and working with the partners, with the field officers, with the PA educators, outreach workers, program managers, we also found that programs were also starting to improve their own program quality itself, and programs were now starting to deliver. So I remember when we, in 2012, if you see the data, the Q1 data, the people coming for STI screening was just 7%, every quarter, which is low. You see, it's bad. After let's say a year, the 7 has become 22. Not good enough, but I would say it's a very good start. We have already tripled service uptake, for sex workers, and so on for HTC programming as well. We are now seeing that the PA educators earlier who do not used to go to the field are now going to the field, meeting sex workers at the ground level. We have seen that from an outreach of 31% only, it's doubled up to close to around 55 to 60% as well, which is good news, because if you don't meet sex workers, you can't provide services to them. You see, services is not manna from heaven. You got to go physically and do it. We have seen condoms per sex worker actually increasing. We tend to downplay condoms because of PrEP and other things. But please remember, condom is still the best physical barrier for HIV prevention. And that is something which was not happening, or what was happening at a pretty much a low scale. So from 14 condoms per sex worker per month, we are now comfortably at least 33 condoms per sex worker per month. At least she has a condom for a day, so that's good news. So things have improved. Needle syringe program has scaled up, from 0.3 needle, 0.3. That's 1 needle per IDU for 3 months. It has now gone up to 11 needles per IDU per month. It's good news for Kenya. You see, so things are scaling up, and we don't claim credit, but we would say definitely that yes, we have contributed to this particular scale up as well. And guys, this is just a beginning. There's still a lot of grounds to be covered. We need to move from 11 to close to 60. So there's still a big gap, because the requirements are around 60. So it's a good start. We are working on it. So the key lessons, when you're talking about a TSU, is that number one, you cannot really have a TSU if the government is not supportive to you. I'm sure the person presenting earlier the procurement story, I'm sure he had a very, very good support from the government to establish a procurement system. Otherwise, it would not work. Same thing with the TSU. You need to have supportive government leadership who own and lead the process as well. And these are very important programmatic values which you need to have in the program. You need to have defined roles and responsibilities, which defines what the government is doing and what the TSU is doing. We always say, as a TSU, never do procurement, never do finance. That's a bit messy. Let the government do it. You do technical support, hand-holding, field-level support, mentorship, so on and so forth. We have seen that if the TSU is based within the government itself, and when I say within the government, they are sitting next to the government, in the government office. Their benches are in the government office. That makes a very big difference, because it increases dialogues almost on a daily basis. Like, I would say hourly basis, or even every minute basis. You cannot do technical support sitting in America, in Kenya. It does not work, really speaking. You start doing emails, and it really does not work. It becomes very formal in nature. Technical support, the TSU thing, really delivers once you are there physically, and you also own the good, the bad, and the ugly. In terms of conclusion, TSU, there are 4 things which it does, outrightly. Number one, it really brings in additional people who are competent enough, within the government system, from 2 NASCOP currently is close to around 16, and that also distributes a lot of workload within the government systems as well. It improves speed because you can do things much faster, and it reduces the turnaround times as well. Because I remember a single training manual took 2 years, but now we can do those things in under 3 months, and that's a very important turnaround times within the government. The program efficiency, effectiveness, and finally, it also brings in the local, managerial and technical, talent. The government has a sounding board within the team itself, with whom they can cross-check things before going external. That's my team.
Yay.
Sitting in Nakuru, the place where the famous flamingos come in, 2.5 million of them. So if you ever come to Kenya, please visit this place. It's beautiful. Acknowledgements to everybody. We work with all the key populations, the sex workers, MSMs and IDUs, the government, the partners, the donors, the Dutch government, so on and so forth. Thank you.